balancing of the joint. And this is the post-operative case. So wherever there is a contraction in the soft tissue or laxity, the robotic technology definitely helps us. Now in periarticular deformity, these are the challenges. There is a distorted axis of the limb. Preoperative planning is sometimes a problem. This is a RT case. So I will just skip this detailed history here and come to the X-ray directly. So this was a picture. Sorry. So this was the radiographic picture. You can see this condyle marginated, 23 degrees of valgus deformity is there, and other side it's a valgus deformity. And you can see here there was a lot of bone loss also. I have some intraoperative pictures also. So we did it robotically, or we mapped this joint, confirm the positioning of the implant on the computer, again confirm the joint line restoration, and then burn the bone. And this is the final balancing of this particular knee, and this is the picture. And you can see intraoperative picture. Soon when the condyle was completely, actually bone had completely dissolved, it was absorbed, so there was no bone on the posterior side. In such cases, you may have to use augments also. So this was the right knee where it was deformed and bone loss was there. These were the cuts with the robotic. You can see the robotic sensor being attached. This is the bone preparation and final X-rays. So any type of deformities we can definitely tackle with it. Another case with the implant in situ of femoral nail was inside with varus deformity. You need not remove this nail and directly go for the robotic surgery. You follow the routine procedures, take rotational axis, adjust it, see the implant positioning, and after that, final position is chosen. The cuts are reconfirmed with a digital injury, and after this, you fix it with the bone cement. So this is how it was finally done. This is the final balancing, and this is the final X-ray. So the implant stays there, you did not take it out, and a cruciate retaining implantation was done. Another case, always implants in situ is a problem. Even if you are doing a hip or a knee surgery, there is a problem. So this was another case with the anteromedial osteoarthritis with medial nail inside. We decided to do a partial knee replacement. There was no lateral compartment involvement. So mapping was done for partial knee. The implant positioning was decided. It was matched to the bone exact with the negative bone. So joint line restoration is done to the perfection. Again, the checking of this implant. So actually, we virtually do the surgery on the computer here, and then burr the bone. Hardly 2 to 3 millimeter bone is taken off, and 4 millimeter from the tibial side. And then this is the final balancing, and this is the final X-ray. So this case, otherwise we would have required to remove the tibial nail, again do a total knee replacement. It would have been very expensive for this patient. Instead, it was just the same partial replacement and completely this was tackled. This was an interesting case, a rheumatoid arthritis case with fixed section deformity. I have a surgical clip. This was done traditional, conventional way. Robot was not used because patients wanted a conventional surgery. It was very osteoporotic bone, and that's why we decided to use implants, which are actually revision type of implants. The video is running in breaks. I don't know, it's not smooth. Wow. So in this, actually, we decided to use stents on both sides because the patient had very osteoporotic bones. So I'm very sorry for this jerky sort of video. Anyway, we did a patelloplasty. You can see the completely destructed bone. We take a intramedullary rod here for referencing for the femoral axis. This is a metal implant, and we have a division nail system here, which was used for this particular patient. Videos are really not running smoothly. So this is a jig for femoral rotation. They have got 0 degree, 3 degree, 6 degree. You can have it as either anterior or posterior referencing. We did anterior referencing. This is a 4-in-1 cutting block which was put. And then we completed the femoral cuts on the with this block. All 4 cuts were taken. Anything can be done to improve the quality of sleep. Like really large, so Then we started the tibial federation. I always take the Ataki line by the rotational reference for tibia. That is the line which we were to draw with the electrocontic from the PCL to medial one third of the tibial tibial processor vertebral tendon. Then you take adequate bone cut. If you always, if you are doing conventional surgery, always measure your cuts. If the cuts are less, then you can recut it and have adequate gap, which is enough to accommodate. So here we're taking 2 mm more because the cut was 6 mm. You have to take more bone from the tibial side. So you always measure the cuts and then go for the further. I think this will just take this video. Anyway, we put the stents on both the sides. So final X-ray were like this. That you can see the long stent on the femoral and tibial side to give additional support for the bone. And since we have to take 2 mm more bone from the femoral side, you have less support on the condyle, and you can see here small posterior condyle. So it's always better to augment it with the fixation with the stents on the other side. This is another video. This also runs. This is an interesting case with a stiff knee and on table. Actually, you can see that this lady had no sort of flexion at all, and this is a intraoperative picture where first of all you have to check it with the patella whether it is fixed fibro. So in this particular case, it was completely fibro. There was no medial lateral movement of the patella, so we have to dissect it in extension and completely take out the fibrosis, arthrofibrosis from the joint. You can use either knife or you can use the electrocautery and completely clean the joint. When you are cleaning the joint, remember that you have to go very systematically. It has to be all 8 compartments. That is the intrapatellar just below the patella. Then below the 3 compartments, the suprapatellar region, the medial gutter, lateral gutter, below the quadriceps tendon, below the patellar tendon, and medial lateral tibial. So all these 6 compartments, posterior compartments. So all these 8 compartments you have to completely clear, and then after clearing all this, you can get some movement. And this particular case, it was a bony sort of a fusion, more or less bony fusion. So you can't bend the knee in spite of clearing all these things. So what we did is that with that time, robotics technology was not there, and unless you flex it, robot also cannot go further. So here, after clearing the fibrosis, I took the cutting block and we took the cuts in extension and with a alignment rod like this. So you can see here the alignment rod was taken, and I put this and draw lines here, and with just your judgment, eyeballically you have to cut the bones on the femoral and tibial side. So you take at a time about 10 millimeters of bone from the tibia and about 9 millimeters. So like that, you have to cut the distal femur and the proximal tibia in one go. So I'm cutting this now this off. So unfortunately, the video otherwise is a very good sort of video. She's just changing the computer. Continue. Okay. So again, I'm going back to this, but it's very interesting case, so pardon me to repeat for repeating it. So you can see here that patella, as I was mentioning, I'll just go slightly forward, maybe. It's actually quite nice. So we again repeat now. You can see here the fibrosis, and you have to be very gentle in this because sometimes there is a danger of peeling of the particular tendon. So now you can see all these 8 compartments systematically, very gently you have to take it out. Once you clear this suprapatellar region, then you go to the gutters. And this takes some time, and you have to be patient and very gentle. Now these are lateral gutter which we are clearing, and the medial parapatellar, medial tibial on the other side. And put this, I use very small sort of extractors. I don't like to use very powerful ones because they tend to damage the ligament. So I use the radius on the retractors as my medial and lateral core retractors. This is the intraarticular fibrosis and tissue. And once we do this, you will see I take out all the bone. But it's completely fused sort of picture, and there is no movement at all in this particular joint. So I have taken this cutting block, aligned it to the second toe here, and the step center. My assistant is keeping the finger on the anterior superior iliac spine, and then with electrocautery I'm marking my cuts here. You can't use any jig here. You can probably use a tibial jig to mark it, but since your joint line also cannot be actually seen, it is very difficult to see that. So your judgment comes in picture. And then with the saw, you cut this bone, parallel bone. I have marked it here. And once this bone is cut, the entire block you have to remove. So once I cut this bone, gently I flex the joint, so you can see that wedge opening. Again, you have to be very gentle in this particular state because otherwise you can fracture it. You can now see that there was complete bony between the intercondylar knots also. So I take it out all the intercondylar sort of bony fusion areas and clear that also. So now it is very easy. You can see posteriorly there is fibrosis, so that compartment also has to be completely cleared and released. You have to be very close to the bone. Don't go far out from bone. Otherwise, there are chances of vascular injuries, and complete the tibial cut. So once this complete tibial cut is done, you check that with a drop rod, check that your cut is in perfect alignment. It has to go to the second toe, and that is where it is coming. And then now on here the surgery symbol. Again check the gaps in the block, check with the alignment rod because the cut which we have taken was completely eyeball. Here no technology is going to help us in this particular case, whether you have a robot or you don't have. Ultimately, this is a case where it is impossible to do with robotics also. And then complete the cuts with conventional jigs. So this is the sizer. Here we've done a posterior referencing. With the hinge we check that there is no notching here. And then complete the cuts here. Once the cuts are completed, then you cement, do a trial, and then cement the joint, the prosthesis inside. This bone also was quite porotic, so you have to be very careful in such particular cases. In India, we get very small bones, our sizes are generally 1, 2, 3, and this also. In such difficult cases, it's very important that we need to be very gentle. Don't use your shoulder force, just with your wrist force. You have to hammer it, and there's a thigh implant being done. Now, another challenge in this is not bony cuts. The challenge here is also the quadriceps contractures. So I have developed a sort of meshing technique of quadriceps tendon, where I take 11 number blade, just like the skin graft you expand with the slits with 11 number blade. So here you can see that I take this particular thing and do this bypassing of the quadriceps tendon, and you can see this is going up to 110 degrees on table with good patellar tracking. This is the X-ray of the patient, and this is about 3-4 months post-operative. Patient is getting good movement. So very challenging case, and you have to really, these cases are there which are actually supposed to be planned properly. You have to discuss with your team and what is the approach, and then perform this surgery. So the lady is doing well. Subsequently, I replaced her elbow joints also and one hip joint also. So she has my 4 or 5 joints in her body, and she's doing well. Another stiff knee. Now that stiff knee was in extension. This particular knee is in flexion. there is just 30-degree movement possible. So here we decided to use rods, and this patient also, you can see that the patient has skin graft, the old post-traumatic case. Now I go to the revision scenario. Now this is one case which came to me, and this was a bilateral revision case. This was operated somewhere else about 2-3 years back, and the patient had this picture on coming. So we did a bilateral revision, single sitting revision in this particular case, and these are the post-operative X-rays, the left side and the right side. So you have to keep your augments, you have to keep your stents, you have to keep if required sleep. Dr. Abram showed me some X-rays just now. That patient required sleep. So in the revision, you have to plan your inventory very carefully and to take it, very. Another disaster case came to me after the case was done some 5 years back somewhere else. Alignment was not there, and this was a picture when the patient came to me. There is complete bone loss on the tibial side. You can see almost tibia is fractured. Femur also a lot of bone loss is there, so you have to keep your inventory in place. So we removed all these implants, we dried it in the single sitting. This was having no acute infection profile was done. And post-operatively, this is the picture where you have used the stack technique of wedges here. We have used 2 wedges here, and 1 wedge on this side, and a huge sort of a poly side also, but ultimately behind the hinge is the hinge prosthesis. So you have to keep your inventory ready in such disaster cases. Another case with a periprosthetic fracture, patient had an aortic accident after knee replacement, and this is how she presented to me. You can see the fracture actually inside the joint, so you really can't fix these fractures and do it. So we decided to use the tumor prosthesis for this particular case, and this is the picture post tumor prosthesis. This revision was done. Another case, this is a video now. This case was operated at our center. She got infection on one side and slight implant loosening, and there was some joint opening also. So this is a video of single stage revision with LCCK implant. So again, you have to be very careful, plan your inventory properly, take your medial parameter approach. Now here, what is important in a single stage revision is that you have to debride extremely carefully every small, biofilm or your synovium has to go out. You have to, so you can see that synovium is being taken out before. That is the first stage of debridement. When the implant is still sitting there, we will take it out from all the 8 regions which I mentioned you. From every region you go so that your under surface of vastus medialis is completely actually visible. So this is the first side. Then in the osteotome you release the contractures, clear from the intracondylar notch, and take out synovium from the collateral ligaments also very carefully. Then after the first debridement, you take out the implant. With the saw, you have to loosen the implant. Take care that there is no bone loss at all while you are removing this. Otherwise, if you are not careful, there is a chance of huge bone coming out of the negative bone, and there will be again a big problem for this. So very gently, with very small, thin osteotomes, you loosen the implant and take it out. So you see no bone loss there. So very nicely taken out implants. Same thing about tibia with a small saw blade. We take out the tibial base plate. Again, we should be very careful. You can see a very narrow osteotome is being used, and then you take out the tibia in such a way that there is no bone loss at all. Then you have to I clear the surface of the bone with the saw, and then you have to remove all the entire cement mantle from the bone. It's very tough sometimes if the earlier surgeon had put a lot of cement inside the bone. And with the ronger, you take out all these pieces of bone. With a cuvette, take out everything from the inside the bone and broach it from inside. Just like we wash the bottle, something like that, very vigorously you have to cuvette it out. Then we saw we resurface take the cuts on the femoral side. So this acts as a divider also. My saw acts as a divider. And once that is there, once implant is out, this is the second step of debridement. You again go around all the 8 compartments and take out all the synovium. Once this is done, we put the intramedullary chip for tibial final cut. So hardly 2 millimeter of tibia is being removed, and once that is done, your bones are absolutely clear. Now this 2 millimeter thin bone, once we remove it, see the here now very clean bone surface is visible. So there is no chance of any big infection or anything like that. You can see the undersurface of vastus very nice. After that, you measure the gaps. In this case, it was around 30 millimeter, 38 millimeters or so that you can plan your implants. And this is the final stage of debridement. Again, once it is done, we give a wash with hydrogen peroxide, betadine mixture, wash it thoroughly. Then you have to remember you change the operation theater, you change the draping, and then go for final implantation. So we have changed everything, changed glove, changed gowns. So it is like performing in two operations in some single day. So that is how you have to plan. And then you again with one lavage, total lavage is given, and then proceed with your implants. So here we are now preparing the tibia. Now the femoral side, this is the for the stem preparation. Then we use these augments and then we take cuts. Now here the flexion gap was less, and so we decided to go one size above. Actual size was C, but we took these to close the flexion gap and took distal augment so that we can close the extension gap. Then you complete the cuts. And this is a trial process with the required augments in place. So then we put this trial processes inside and check the stability of the joint and then decide the final size of the body. We have taken a 10 millimeter distal augment and 10 millimeters of 5 millimeters of posterior augment, and then you can see 5 millimeters of tibial base. And now we are checking the stability. It seems pretty good, so we are now ready for final implantation. We tried one more poly size and then saw the stability, we saw it better, and finally we chose this particular poly. It's absolutely stable joint. And the tracking also is good, so that's the time when we again give a watch, and then we are ready to go for the final implantation. So see how clean the joint has become. So like that, you have to be very meticulous in your debridement and then do some multiple small drill holes so that your cement is good. This is the preparation for the revision implant, where we fix the final augments and the wedges to the implant. They take 2 packets of bone cement, put it on the prosthesis as well as on the bone, put some bone cement inside the medullary canal also, and then finally you are ready to implant the femur. With thumb, you have to ensure that it's pressurized nicely, the cement, and so it's a very rigid sort of fixation. Then on the tibial side, we press the cement, put slight cement, some cement in the intramedullary canal, apply cement on the proximal part of the stem, and then put the poly and lock it. And you get a locking screw also for LCCK implant, and this is how the final implant is there. We use the vancomycin beads, absorbable beads in case of infections. In fractures also, in trauma or any disintegrated vancomycin beads which are put inside the joint. So before closure, we put these beads, and this is how revision is done. And this is the final X-ray of that particular patient. I will show some big cases. I think this is an alien case. Nowadays we use this dual mobility protection. Medical has launched it in India. There are some companies which are having dual mobility. The advantage is that you get full movement. Patient can actually squat down. Patient can sit cross-legged. The stability is fantastic. There is a long literature from France which is available as far as the dual mobility is concerned. So I do all my hips with the posterior approach. We split the gluteus and then expose it from the posterior side. The Chandley's refractory is applied very close to the bone. We cut the rotators along with the hip capsule in single layer. I don't separate the 2 layers because for suturing it becomes very sturdy, and you can suture it back very well. So once this completely exposure is done, hip dislocated, check the length, and then do a neck osteotomy. Once that is done, then we take off the head and we have to expose for proper. My students ask how what are the landmarks for the acetabular placement. The best landmark is the natural anatomy of the, unless it is a case of a DDH or something like that. You have to expose the acetabular 360 degrees, and from all sides you can see that it is completely visible now, very nicely seen from all sides. So it's really a child's play to put a acetabular implant. You have to take off all the osteophytes. That's very important to determine the actual acetabular border or the lip, and take off all these osteophytes. This is very important in hip case. If you don't remove it, then it can river out the hip and cause dislocations of the hip joints. And start reading. In reading, you have to be gentle. Use sharp reamers, but you should not apply a lot of force. I generally do one size less reading. If you have to put a cup of 52, then go to 51 reading. Clear it once the fresh reading is there, then you know that the time for implant has come. And then after this, as several final implant I do. After trialing, if the fixation is good, now you can see that if you are trying to move the entire patient moves. So you can use screws, you may not use screws, if depend on certain choice. If the fixation is really rigid one, then it's not mandatory that you have to use screws. Here it was good fixation, but still we decided to use two screws for secondary fixation. Then give lavage, and then dual mobility comes that there is a shell here now. So this shell goes inside the acetabulum. And on the femoral side, it has got 22 or 28 head, and then there is a poly. So there are two interfaces where the hip will have movement, and that's how you can get full range of movement in the hip. And on the femoral side, we start preparing broaching, and you have to get this is a Korean-like stem from Nerel. I've been using the implants since their company started, and I have had good results with those particular products. So after this, then you have a trial reduction, and this is how the dual mobility cup looks like. You have a poly cover, and there is a head. Once that is done, you measure again that your leg length is restored. It's very important to do this step. So we have ensured that the leg length is correct, and with just thumb pressure, you should be able to reduce the hip joint. And you check the movements now. Everything is okay, then you are ready to have the final implantation. So this is a Korean stem, trapezoid stem with this very good rigid fixation is possible with this. There is hardly any case where in the last 32 years of my practice, I did not have a single case of subsidence with this kind of stem. And this is how the dual mobility head is locked. You have a ceramic head and a poly outer layer, the interface there, and they lock each other with double click. And this is how the head moves inside the second head. And this is how you get double movement here. So the hip is reduced, and you again check for stability and movements. So this is the post-operative X-ray of the patient, and this is the activities of the patient. So patients with dual mobility can squat down, they can pray. I get a lot of patients from Middle East, they require to kneel down for namaz and their prayers. So this is how they are able to do everything. They are able to sit cross-legged, they are able to kneel down. So that's the advantage of dual mobility cup. And with your proper testing, this is another case of dual mobility. This lady had done hip replacement with dual mobility. So she also was having demand of full range of movement. You can see that very easily they can squat down, sit down, which was very difficult with the old routine hip replacement implants. Another very challenging case which I have faced is this was a Yemeni patient who had come with an old trauma and completely fused hip, and there is nothing visible, no borders or seen. It was really a tough case to find out the true acetabulum. We had to take intraoperative X-rays. We did in situ osteotomy of the neck, dislocated it, and since the entire capsule was calcified, we had to excise it. So we used the constraint cup. This is another case. Do we have time or should I have one or two? Yeah. So this is the last video. This is the, or should I skip the video? This is the PDH. I cannot take it forward somehow. Another case is the PDH, bilateral PDH, where we operated this Omani girl and did a hip replacement. Now, in these cases, you have to do a subtrochanteric shortening osteotomy so that you regain the length and gain the stability also. You have to read this and prepare the femoral canal. Broach it. Now, here we use what is the special thing called S-round hip, where the fixation is completely in the proximal triangle because we have to do a subtrochanteric osteotomy, lengthening osteotomy. So here we do this, osteotomy, cut the bone, then see how much the shortening to reduce the head, and then reduce the head and do the HR. So anyway, I will go forward. Another case of PDH which was done. You can see again the same procedure is done, and with this we get a S-round hip, and we have to gain the length also, and gain the acetabulum in the proper thing. We did a bone grafting on the superior leg. Here is the osteotomy and the bone graft here, and we have restored the length in this particular case. This is another case. This is a Ethiopian lady whom we operated. Old. She was here in fact yesterday. This was an old sort of tonsil arthritis where the hip was like this for 40 years. So we did again a subtrochanteric osteotomy. Did brought the femur down. You can see the osteotomy site here. Use the S-round hip and friction up on the this thing inside, and this lady had got a lot of publicity in India also because this was in times of India. Her case was reported after 40 years. She gained the length, and here she was with me yesterday. Another similar case with the high riding hip. We did a S-round again. So these all S-round cases. I have the largest series of S-round cases. This is a case of revision where the acetabulum is completely destroyed, femoral side is also destroyed. So we have used the cage in this case and did this particular revision PHR. Another case with completely destroyed acetabulum, we had to use the cage and we used the long stem on the femoral side. This one more case, this case was reported. This was the fourth revision actually. This is the fourth surgery which we were doing with all this metal inside, and there was all the screw had broken as it was blasted completely. Very difficult case. We had to take the acetabulum out, all the hardware out, all the intraoperatively the synovium looked like this. Complete necrosis was there, so it took some time to debride, and finally we got the hip inside, and this is a post-op X-ray, absolutely fantastic. This patient, another difficulty was 130 kg patient, very, and this is 5'8" and 130 obese patient. So there are a lot of challenging cases like this. This is the bilateral revision case. We've done this thing. This was a bomb blast case from Yemen. Their ward patient, and you can see the acetabulum is completely destructed. So we had to do the bone graft from the head. We did a jumbo cup here with a friction jumbo cup, bone grafted it, and fixed it with friction with multiple screws. So this is the final picture of this picture. This is almost now 5 years post-op, doing fantastically well. And this is a case where, again, 3 revisions were done, and the patient reported to me like this. This had completely migrated inside the abdomen. So in this, it was a challenging thing, and one should remember that the IF vessels are in close proximity of the cup, and you should be careful. So for this, I went anteriorly retroperitoneal, was isolated the IF vessels, which was absolutely sticking here, and one of the screws was almost penetrating that, and we had to carefully remove the acetabulum from anteriorly. Then we removed the head also. Then when closed that wound, went posteriorly and did the revision of this particular case. Again, acetabulum was destroyed, so we had to use the cage here. And this is the final X-ray of the patient. So these are some of my cases. Every day we do 20-25 joints, or maybe more, and every day face some challenging cases. I am really thankful to all of you for allowing me to share my cases here, and very sorry for my computer which is beyond my control. Thank you very much, sir.
I am very which not really fast, kind of long lunch, so tired. Now let's have other talks. Finally, we wrap up and we have extended lunch time for socialization. The next papers is chaired by Yana is a PhD, just finished, he just finished PhD. Yana is orthopedic anesthesiologist. This is a new title we gave him. He has office in orthopedic, he is interested in orthopedics, MSK anesthesia. He is our great friend. All is the first anesthesiologist in patient lives. Born mother, the other was orthopedic customer from India across the lips, still used for grafting that area. So without him, we can't do anything. Aram goes on. He's interested in trauma. He published a big manuscript plus 2-3 papers on pre-hospital care. Sometimes we can power not to paper on this, we know patients when they come to the hospital. What happens between injury and hospital or requirements. We published on that. Community based center, an excellent paper. I invite you to read. We published those papers. And there is then you can look and say pre-hospital care, report presentations. He is also my good friend, maybe more than 10 years. We have been working together on medical legal bonds, represents anesthesia side. And today, this is important. When we focus on surgeries, we miss this part. And once you have a problem, it's a big problem. Therefore, as a reminder, we include this in the ESOT presentations. He's going to talk. What are the claims? What the patients claim on us? We have this talk 2 years back, but again and again, we have to do always see claims, changes, so that we'll be careful with our practice and we will remain protected. With this said, Yaya, you are ready to present. The podium is for you. Cheers.
Thank you very much, Professor. So, as he introduced me, I am Yaya from Addis University Anesthesia Department. I'm an assistant professor and final year PhD student, just awaiting the graduation. As he said, I'm interested in trauma care. As you know, in our country, the trauma care system has a lot of results. So, my interest is just as a team, we have to improve the trauma care system in this country. But today I'm coming with another topic, which is more focused on the medical legal issues. I'm going to report the medical legal issues which are investigated at Addis Ababa City Administration FDA or FDA matter from 2015 to 2027. By this occasion, I need to thank you, society, to give me this chance. And at the same time, I'm happy if you give me an opportunity to thank my advisor, Professor Brugger. He is my advisor when I was doing my PhD. Thank you, Professor again. So, as I told you, this is just a real scenario, a real report that we face in the medical legal community. These were the co-investigators working as a committee member, and also they had contribution to this research from your society, Dr. involved. These are my outlines. So let me say something about the background regarding the medical legal issue. As you know, health professional care system by itself requires adequate knowledge, skill, and aptitude. No health professional wants to harm patients, but even if we are doing to the best of our knowledge, to the best of our skill, some occasions may happen. In that scenario, medical legal issues may be, or lawsuits may be happen. Medical legal issues is with medical law and the right of that's professionals and patients, and that professionals have legal duty to adhere to reasonable standard of care while interacting with patients. They are also involved applying medical knowledge for legal purpose. When you see the overall pattern of medical legal issues in the globe, we have tried to see different features from different corners of the world. For example, as you see from here, a study done in Saudi Arabia, medical legal issues are more occurring in operation room and emergency departments. And surgery was the most from specialty for medical legal cases or procedures. Another study from India, most medical legal issues are related with road traffic accidents, and men are more affected than the other age group. Another study from Egypt shows that medical legal issues are more claimed in relation with surgery and obstetrics. In Pakistan, again, it is similar with that of the India, which is more associated with road traffic accidents. In our setup, as you all know, Professor Brook and his team have conducted the research from the Federal Ministry of Health Professionals Committee. In that study, 125 cases were investigated within 7 years. From that study, we understand that 57.6% of medical legal issues were associated with deaths, and 94% are coming from hospitals and related with surgery, and in some of the cases. We are also trying to see what are the driving force that push the claimants to claim for medical legal issues. There are a lot of literatures regarding this issue, but the most common factors are associated with financial motivation. Most commonly, they need reimbursement or financial support after some incident happened in the hospitals. After saying this, let me tell you something about some information about the committee that established at Addis Ababa City Government, FM office. This was established in 2020. By this time, I want to acknowledge Professor Brook because he was the founder of this committee in this establishment period. And he was the president and the vice president, the chairperson for that committee. And the committee was established by proclamation number 30, 2012, and it has its own guidelines and SOPs, which it follows when cases are investigated. These are the committee member composition, which has which includes different professional societies, youth societies represented there. And to know you, because when I had some discussion with my colleagues, they do not have a understanding about the composition of the committee. If you see at the last this area, there are 2 representatives from the House representatives of Addis Ababa City and 2 legal officers from the FDA and from the Addis Ababa Government Justice Bureau. So far, this committee has handled 282 cases. From this, 210 had been investigated or included in this study. Our interest, why we need to prepare as a research is, even if 282 cases have been opened as a medical legal case, the pattern of this medical legal issue is not where the study, and we need to show for our professionals and for our stakeholders. This is the general objective, that is to assess the pattern of medical leadership and challenges encountered in handling cases at Addis Ababa. The study is a mixed method study due to the time constraints. Here today I'm going to present only the quantitative one because there is no adequate time for organizers. But the study design was explanatory sequential mixed method research, and the data was collected from 2015 to 2023. And we have got IRB approval from Addis Ababa University and support letter from Ethiopian. Now let me come to the results. First, we have tried to investigate the biographic data. Almost 92.9% of claimants are coming from Addis Ababa, and around 3.3% were from other regions. When you see the age, the majority of cases which the committee investigated was between 18 and 45 years of age. Then gender distribution, female cases were more dominant than male. When you see the ownership of the health facilities from which the medical legal issues are raised, private institutions were dominant, that counted 55%, and government hospitals were 40%. Who brought the case to the committee? Claims around 34.8%, related families are 33.8%. Sometimes cases are brought by police, and it was accounted with 2.4%, court around 0.4%, like that. Patient condition at admission, management at emergency department. Most cases which have been investigated at the committee was the other were emergency or cold cases, but not emergency or cold cases, around 37.6%. From this, especially for life-threatening emergency condition patients, for 27 of them, they received CPR resuscitation. Around 4, they got ABC, the management for resuscitation, the other supportive cares. We have also investigated whether the duty physicians were in duty or not when the patient came for seeking of medical help. Yes, the primary health professionals were available around 64.3, but only 8% of the expected duty physicians to be consulted as a second consultant were available. When you see the medical legal landscape by specialty, as you see here, the majority of cases were obstetrics and gynecology, and the second one was, as you see here, the general surgery, and use discipline is on the second place. Okay? On the second place. We have also tried to assess the clinical status and confirmation cause of this. Hemorrhage, hypoxia, cardiopulmonary arrest, multiple organ failure, and this one where the causes has been investigated by the committee. The reasons for complications, actually, one of the was presented before about GA diagnosis and treatment, and the major cause why health patients or their patients often medical legal care was delayed diagnosis, delayed referral, and delayed treatment. This was the main reason that we found in our investigation. The other one, we have also asked us whether there was limitation in resource or in other scenarios, and we asked for the availability of resources in that facility. Only 41%, 90.5% were answered that there was no problem on the availability of resources, but 37.6% say that no, there are appropriate resources, especially on the emergency department. The limitation of the resources were lack of emergency medication, lack of oxygen, lack of medical equipment, and in some institutions, lack of service provider, like the ICU department, the NICU, and the other. The other one, why they open the file to this committee? Because the majority of the claimants, they think that medical error has happened. It's around 49%. Some of them, they need reimbursement. It's around 40%. Some of them, they need to teach that case to help for other cases or for other individuals or each others. The other challenge we found is the committee found that there was a big communication gap with the patient and with their relatives. And it shows that 71.4% of cases had communication. The communication gap was unable to deliver the right information to the right people at the right time. This was the main challenge that is why claimants often face. Ethical breach was identified by the committee. It was around 69. From 69, the ethical breach was 23. Negligence, malpractice, and treatment error was 69.7%. This is the disciplinary measure by professional category. OB/GYN is the first, it's around 40.6. Clinical is the second. General surgeon, midwifery, and yours is on the fifth. Disciplinary measures taken by the committee was oral warning with a letter of warning, revocation of the license. Revocation of license for 4 to 6 months was the highest. And as you see, there are different disciplinary measures taken by the committee. At the same time, we are also time section of the other, let me learn 2 minutes. Okay? Ethical committee has recommended a significant action for the health facilities, like that of oral warning or written warning. Even the committee has decided to close the health facilities. The discussion part, let me focus on the most important things. Okay? Already, it is under the publication process. Within 2 or 3 weeks, it will be published already. It has finalized, so we may get it in the website. So, I need to focus on some discussion. The majority of cases are related with OB/GYN. This is aligned with the study done in the US. And in Egypt also, the potential explanation was complexity of care, communication gap, and systematic care. The implication is here where we have to improve the communication and enhance our approach. The other one, the major problem is the communication gap. In our study, 71.4% of medical legal cases were related with communication gap. This was similar in the study done in Australia. The potential reason was because health professionals are working in a complex area and complex medical information, time constraints, lack of cultural sensitivity, and this helps us to improve our communication skills and emphasize patient involvement in our care. And this is my conclusion. My conclusion is high expectations, a significant portion of the chronic cases involves critical need patients, suggesting potential issues with early intervention or resource limitation. Communication gap is one of the major challenges, so we have to work on improvement of communication gaps. The other one is disciplinary measures. OB/GYNs and surgeons are the most as professionals to face for such like disciplinary actions, so we have to work with them to improve their approach. And the other one is delayed collaboration. So again, I advise or we advise that professionals as much as possible to start their treatment as early as possible. These are my recommendations, and the references are there. Thank you very much.
Thank you, Dr. Yayana. Now we will proceed with the next presentation. I'll invite Dr. Fahri.
Thank you very much for giving me this chance. I think this innovation type of how to treat concurrent fracture we practiced for the last 30 years, from 2011 to 2014. And my objective is to introduce medical population practice, difficult of oil, complication of oil, and objective and summary of our innovation, oral sample, new method, and recommendation. As you know, the calcaneum is the most frequently fractured bone in ulcers. Various classifications have been proposed according to the deformity and the disruption of the calcaneal joint. The poor outcome following fracture has led to many methods of management. Namely, these are the methods which we use, but and then the difficult one we see is the prolonged operation time, infection, skin necrosis, close fixation, and prolonged time of recovery. These are some complications we see with the fancy plants. When we come to our method, these are the main important. Crash fractures of the calcaneum result in the deformity of the long axis of the bone. This deformity is maintained by the pull of the tendon calcaneus. The deformity is reduced by eliminating the deforming, which is the calcaneal tendon. Crash fracture of the calcaneum also before the facets of the calcaneum is articulated with the talus. Release of the deforming force allow the unopposed pull of the plantar fascia to recreate the longitudinal arch. This also allows the deforming calcaneum to molded by the undamaged facet of the talus. In addition, the intense pain from the disrupted subtalar joint is relieved. Molar cycle improved as the heel is pulled down by the plantar fascia. Weight bearing in a plaster probably helped to mold the facet into a functional position. I think this is a polar angle, it's good. We have in these 30 years around 38 patients, all were aged from 15 years to 50 too hard a bilateral fracture. They fell a mean distance of 4.2 meters, minimum of 1.3 to maximum 9 meters. The cause of the injury was 25 working accident from construction, 7 suicidal attempts. This happened at that time. There was the people who were working outside in Ireland. There were these 7 suicide attempts. 6 were from moving vehicles. There were 2 fractures on the lumbar spine and 1 point trauma. This patient, when we saw him before treatment, he has only 5 degrees of border angle, and then after the treatment, he has around 75 degrees of border angle. This is the second. From 9 degrees, we brought to 79 degrees. This is the third patient from 10 degrees. The fracture you see, we don't classify. Simply we put the border circle is up to 70 degrees. These are the whole patient's list, and then the average improvement is from 5 degrees before surgery up to 70 degrees. These are the whole patient. This is our treatment method. In this case, we encourage swelling to resolve. We use a posterior plaster cutter and elevated until the swelling is subsided. With a tourniquet, a paramedial incision, expose the tendon and we do coronal plane Z-fascia anatomy, and the tendon is not stitched, simply we stitch the skin, we leave it there, and then we apply a short leg cast. Here you can see the thumb is pushing the arch, the medial arch of the foot. These fingers are pulling the calcaneus. In this case, when you come to, we put the stem P on the posterior side of the calcaneus, and then we pull it down, and then this hand keeps the foot in right angle of the ankle. Here we see our 2 hands compress the laterally and medially to bring the normal side of the heel. This is in the last, and then we wait this patient until sometimes we advise the patient to walk the next day as he tolerates the pain. We give a strong analgesic, and in the 3rd or 4th day, he already can walk with a small pain, and then we see this patient every month, and then we see they walk without any problem. This patient is the first we treated in this. As you see, this is the affected heel, and then they can start with the toes. Here you can see the injured one, it is laterally. And then we have seen none of the complications about this patient. I think some of our junior consultants, especially in Awasa, Dr. Efrem, treated some patients with this method. There is no reported complication. Recently, I think 3 months back, I treated the last patient, and then he has good. It's a very good Brahman, and after 3 months, we removed the plaster, and then he went to the medical board to be compensed compensation. I think Dr. Musekiri, the compensation, is working now without any problem. He came from Gambela, and now he has no problem. And that's what it's called. I think for those my residents who were in this time, many of them participated in this operation. I think this can help us. The procedure is accompanied in a health facility with not limited resource, excessive resource with limited use. I think some Western they say limited resource. We have excess resource, but we have a minimum use of our resource. Here we don't see complications in all these patients. No need advanced medical technique, less basic surgical procedure. Surgery can be done by any operating within the new individual. Post-operative care is as recommended. Unless we do that, this patient, you can have the good result. What I see from my experience in lower limb injuries, early weight bearing that will keep the quality of the bone, even the healing process is going forward. But if we see in our body, they wait until the fracture begins, and then they start to rehabilitate. For that, my recommendation is as early as possible to start with this. Thank you very much.
Very much, Dr. Brown. Thank you for this presentation. Now we invite Dr. Gitana to present the atypical post-operative artery vascularity, secondary to ROG, which is the case.
Thank you. I'm on the orthopedic resource to know that I'm from 5 minutes. Sorry. So, we run orthopedic surgery staff in Bombay University, but I'm currently working as a community service in the Crown for General Hospital. So, this is a case of atypical cause of femoral artery vascular injury. Secondary to ROG. I don't know how many of you know another. So, you know, most of the vascular injuries are from related injury, fracture related injuries as a penetrated surgery. So, this is the outline of my presentation. The objective introduction is presentation management. So, what was the challenge that we encountered during the management summary, acknowledgement, recommendation, and then final results. So here I want to emphasize to know about what's how it's injury, truth about the injury pattern, understand the techniques of removal. So I'll show you this slide. There are difficulties sometimes to remove the arrow and to understand the peculiarities. So it's not like other injuries. There are peculiar features of this vascular injury following another probe. So definition, arrow is a sharp metal. Mostly it's a metallic object to be made from plastic. Sometimes can be from a wooden part of the instrument. Traditional design is different parts. So it causes an injury by perforation or laceration or cutting of a body part. So this is a classic picture taken from an organ. So technically it has three parts. So the bow of an arrow. This is the strings, you know, the proximal as well as the distal string. This is basically what I'm talking about the arrow. So by drawing the string part of the arrow, it creates a potential energy. So to maintain the potential energy, to store the potential energy, it creates high energy and stores maintenance at a fixed point to result in a kinetic energy causing firing of an arrow. So this is basically the part of the arrow. This is a technical, image, formed by this is the real part of the arrow which is attached to the other part. This is the body. This is a critical part of the arrow which requires extensive and meticulous technique to remove the part. And this is the broad strip, the sharp strip with side cutter, and this is the wooden part. Basically, this is the wooden part of the arrow which is attached with the real part of the arrow, and actually it doesn't show here. There are strings of arrow which are the wooden part, as well as the real part of the metallic part of the arrow is attached. So this is the demonstration of the analysis. When it comes to the history of arrow injury goes to antiquity. So there was the first documentary history in South Africa around 17,000 years ago. But currently the incidence of arrow injury is rare, and so it's rare worldwide. There are common injuries. Actually, we face around the leading research was the first leading cause of trauma in Power General Hospital, even though the prevalence is very worldwide. And prevalence of vascular injury following arrow trauma is extremely I've seen some case reports, but there are around 2 or 3 case reports worldwide. So another side of involvement can involve the chest, abdomen, thoracoabdominal disease, which is how it came with resistance, resulting in open thoracotomy removal. This is another case of arrow trauma. This is a case where the arrow is the entry side, as you see from here. So this is the entry point towards the anterior superior left side, tracking all the way, including the pelvis and exit over the greater shaft. So this is another case of difficult arrow which is inside, starting in the pelvis and just going posterior to the neurovascular structures. These are the different types of musculoskeletal injuries that we face in the hospital. This is another case, it was a difficult case. The patient removed the wooden part of the arrow, and we couldn't see the injury side. But lastly, after 2 weeks of injuries, came with an infection. We took X-ray, it was completely inside the body, and we removed it successfully. So when you come to our night case presentation, this is a 25-year-old female patient. She came after sustained arrow injury from a close family, and she was referred from private care center to Power General Hospital. And upon examination, the pertinent finding was, this was a case. So there was an in situ arrow on the medial side of the middle side of the thigh, and on upon examination, the distal neurovascular, the distal substance and posterior valgus was absent, but fortunately the shaft nerve was intact. So we took X-ray. This is, as you see in the picture, trajectory of the arrow from anterior to the posterior lateral side. So we can't do the ultrasound examination because of lack of staff there. So I offered the options, but there is no trained vascular surgery. So even if the patient was referred, it's around 800 km from the center. So 3 days, 4 days by the time the patient was survived. So I decided and gave her the option and explored it, and this was the improv finding. So the arrow was stuck in the superficial femoral artery. The superficial femoral artery. So I decided I will take the steps how to remove this difficult. So the first step, after anterior incision, getting the anatomic side of the vascular structure side by getting the posterior lateral aspect side, try to find the exit side. So I don't know whether this is visible. This is the posterior lateral aspect of the thigh. Try to search it in the posterior lateral aspect, and the arrow is exiting between the posterior lateral structures, transiting the same tendinosis. So what was the second step, I just applied the vascular clamp, as you see from the blue line. So externally and distal application of the vascular clamp. And there was no active layer because the arrow was acting as a tampon from preventing actively. So the third step, this is shows application of vascular clamp. This was the only clamp that we have our setup, but this shows you the application of, this is a blue vascular clamp. So the third step was, detaching the wooden part of the metallic arrow, as you see from the previous slide, and I tried to detach the wooden part of the arrow from the metallic part. And the fourth step, it was unidirectional. The serration of the arrow was unidirectional. So we can't pull it because it teasers the neurovascular structure, especially the sharp. So what was the technique is removing the line of trajectory. So I try to widen the exit side and always roll. Then after the removal, the final step was vascular repair using standard techniques, and this shows after vascular repair, this shows its final step of the repair side. So finally, when it was closed primarily, is splinted for 3 to 4 weeks, and this was comparable with the contralateral limb after 12 hours and 24-hour follow-up. Evangelitis for 48 hours given spring in this way. Finally, we checked that 1 month follow-up shows fine, it was really fine, and that was the case. So what are the peculiarities of our vascularity? Usually it's an isolated injury. If you see related injuries are the fracture related injury, there is associated significant associated injury. But this injury is usually an isolated injury. It doesn't cause a weight injury, it doesn't cause associated muscle injury. So there is little risk of thrombosis. So because of the thrombosis is either from direct injury or from the weight injury. But here the risk of thrombosis is low. And there is no exaggeration. So as I told you, so vascular injuries from other traumas has a significant exaggeration. But Zara was actually an advantage because it acts as corticosteroid effect. That's the peculiarity. And it has better outcomes than other injury mechanisms. So what was the challenge in sustained setup? So we don't have a lot of proper imaging modalities. Sometimes when you are in a dilemma to diagnose vascular injury, there is a limited imaging modality. Lack of proper response. Actually, this is where the only the vascular clamps available that I did in the setup. So we don't have other proper vascular instruments. And lack of trained professionals. So there was a general surgery, but those guys was referring to the patient with vascular injury. But even the assistant were not trained professionals, they were GPs and nurses. So this was the challenge. Even you don't get the proper stitches for vascular injury. You deal with 5-foot rolling and absorbable stitches. That was the challenge we found also. In summary, vascular injury following our trauma is extremely removal techniques. Removal requires meticulous technique to avoid secondary injury from the lay part or the hook part of the arm. And thorough clinical examination is important to have backup plan in the setup. My acknowledgement is was the University of Gondar Department of Orthopedics who gave me the chance for community service and with the community service in the remote area. And actually, this was the single thing for organizing vascular course. This goes back to 2022, while I was finishing my residence program and got the chance to train for vascular therapy in that period. And finally, the Black Lion Hospital is the mother department for organizing all the such courses. My recommendation is to better from orthopedic surgeons on basis of this cardiovascular therapy, as is primary, and will allow some of the same type of solution. These are my friends.
Dr. Keitara, that's an amazing case. Now we invite the final presenter for this session. It's going to be the source abscess by retail placing in the pediatric patient. Dr. Brook.
Hello everyone, good morning again. So I know you all are tired and it's been a long day. So you come across a lot of presentations. So maximum I'm gonna use 5 to 7 minutes. So today I'm here in front of you to present a case report. So my name is Hassan. I'm coming Pax Division in Sodocure Pax program. So I'm from Sodocure Christian Hospital. So most of you know about Sodocure Christian Hospital. So it's well known by the name Dr. Reina Person, which put a great effort in modern orthopedics in Ethiopia. So in this project, we took global informed consent. So for publication of this case report and the images which are incorporated in this image, in this case report. So we'll have through case presentation, the management, and we will have discussion and conclusion sessions. So on arrival, on his first arrival to our hospital, he came with a history of, he was a 22 years old male patient, presented with discharge and pain at his right hip of 7 months duration. So prior to he present to our hospital, he visited a nearby hospital. So at that time there was no discharge. He went there just with right hip pain. So they did ultrasound. After ultrasound, needle aspiration was attended, and they sent it for MRI. When this unspecified MRI finding, they started him antibiotics. So after he took the antibiotics for about a month, he started to have swelling, which extends from this proximal from this greater 200 down to this distal femur. So with this they did his first surgical drainage, and they discharged him with antibiotics and wound care. So while he was in wound care, after several months, he started to have another discharge, and they repeated his X-ray, and the X-ray showed there was some kind of bone formation around his hip. So they repeated his surgical drainage. Then after he was in follow-up there. So his discharge was persistent, and the plan was to repeat another surgical drainage. He refused and he came to us. So upon arrival to us, he was a bit traumatized. He had 2 surgeries, and he's young, competent, but his discharge was very ugly, so he was a bit traumatized, and he denied any history of trauma apart from the surgery that he had in his previous hospital, and he had
no chronic medical illness. So we did a physical examination. So he had no record of fever and no tachycardia is vital to stable. So on musculoskeletal examination, he had sinus tract. He had sinus tract just posterior to his greater throat handle, right side, and this is the previous surgical scar which was done in previous hospital. So his hip range of motion was full. He has no pain while moving his hip, and he has no limbs discrepancy and his distal neurovasculature were intact. So with this, we investigated him with we did blood workup as well as imaging was done. So from his blood workup, his WBC was a bit raised and had left shift, and his serial protein was 10.7 and ASR was 26. So this was the image at his arrival. So as you can see here, there is a soft tissue calcification around his laser throat with an impression of deep soft tissue infection, chronic deep soft tissue infection. We managed surgically, so we used his previous surgical scar and we followed the sinus tract. So the finding was there was thickness with granulation tissue and granulation tissue and soft tissue calcification. So culture in biopsy was taken, and the culture came out with a no growth. So we clinically suspected TB or some kind of anaerobic and clinicalizing, and anti-TB was started. So on his first follow-up, he had still on and off type of sinus discharge from the surgical side. He's adherent to his anti-TB, and he finished his 6-week course of clinicalizing. And the CT scan was done in his follow-up, and it just shows only soft tissue calcification in his laser program. So on his second follow-up, the discharge became more turbulent. He was depressed. He became more. He was losing hope, and he still, in spite of the discharge, was taking his anti-TB medications properly. So everybody was concerned, everybody was worried, and we planned to have an MRI. So MRI was done, and radiology department communicated, and the MRI revealed that the sinus tract, which communicates with his skin posterior to his around his laser throat, proximally extend to the psoas area. So in his psoas area, there was an hypotense possible foreign body with surrounding hyperintense kind of fluid collection. So we tried to dig history. We came back with, we tried to dig history. We asked him if there is any trauma, if you have any history of surgery to his abdomen, maybe it can be ethogenic. So patient denied he has no history of trauma. And he went back home and he called us and have a history. I fall in a pencil while I was playing with my friend 8 years back. So he came back with this history, and we revised the MRI and the CT scan that we did in his follow-up, and it goes with history. So surgically we removed the pencil as a single piece. We used pseudo-transverse anterior pararectus approach, which is primarily designed to, which is primarily used to fix the anterior acetabular wall and column fracture. So this is the pencil, which was removed as a single piece, as you can see here, and this is the surgical scar, which we approached to remove this the pencil. And in his certain plate, the drainage from the around his greater throat handle. So this is the last follow-up, 7 months post the surgery. As you can see here,
the sinus tract, the previous surgical site were healed, there is no discharge, and the scar or the we are forced to remove the pencil was totally healed. So in discussion, the ESOT service is a coolant collection in around the psoas and iliac muscle. So based on the etiology, it is classified as primary and secondary. Primary is mainly caused by hematogenous split, which is the most common type, and the secondary one is from direct split from the nearby structures and retained foreign bodies, like our case. It's rare. So in conclusion, psoas residual foreign body is rare because of its various presentations, diagnosis will be late. So to reach diagnosis, detail and thorough history and physical examination are called for diagnosis, and imaging modalities like CT scan and MRI are very important to reaching diagnosis. So not all foreign bodies should be removed, but selected cases which are infected and which are symptomatic should be removed with a surgical approach. Thank you so much.
Right. Ladies and gentlemen, we launched the presenters quickly, please come forward. We have seven talks from Arno, Peterson, to the Robert, Versace, all of them. So we'll expect few questions. We are few with my colleagues to accept as many as possible in another asal kalau industri kami bisa sudah tegak bagi gizi berkembang sahabat kita sesuatu yang ask questions quickly. The first president of ESOT, Dr. Lakas, never tried to collect anak-anak itu. የመጀመሪያ የሶስት ፕሬዝዳንታቸው ዶክተር ለገሰ ናቸው። ይኸው ፊት ለፊት ማይክ ብቻ እዚህ ጋር ፊት ለፊት ፈርስት ፕሬዝዳንት
Thank you very much for all the presenters. Actually, this was very interesting and profound. So I can say myself, I'm a little bit more academically tapped. It means that the presentation is over stimulating. So I have a few questions on actually the level of trauma care. I'm very glad to see that many research have been going for pre-trauma hospital care, and the factors are very vast, and there are different stakeholders who are involved in such management cases. So I'm very glad to hear this report, and I also thank you for the presentation. So I think when you give your presentation, there are two categories of the delay. One is pre-hospital, the second one is inter-hospital. So when it really comes to inter-hospital, it's the pre-hospital factors, as it mentions, there are plenty of them, including the patient's choice, the family factor, the second person opinion factor, the community attitude factor, even in some areas, structures are also contributing for the delay, particularly because of injuries. When it really comes to hospital, I don't really complicated. What was the main reason why there was a delay within the hospital to refer to proper safety? Is it really because of logistics reasons, most of this is South Africa, or is it really because of professional factor? If this is a professional factor, what is the plan just to improve, these delay times?
Because nowadays, protocol is established and in the world, different countries have established their own trauma care and protocols. So, what was the main reason for the inter-hospital delay? And was there anything that was identified, and what is the way forward? Thank you very much.
Thank you.
What's up? Thank you very much. I just would like and my question was at first a very simple performance or outcome or I'm speechless, okay? But my question, one simple question to leader is a leader replacement, meaning the partial leader replacement. I don't know, in the joint replacement, the main focus is comprehensive, joint comprehensive. If I'm not mistaken, I think I have seen that there's some scales. Could you tell me, or can we draw out the picture to be clear? The second question was to performing.
So from UNC, so some speck of looking, uniform. So you explain, I think our answer.
The partial visual replacement.
Actually, we check it intraoperatively, and the X-ray looks like that because the poly is not seen on the X-ray. So the poly of thickness of 8 millimeters goes between the metal plates. So actually, there is no setting.
In the partial visual replacement.
Yeah, there is no step. We have the metal base plate, then on that metal base plate, we have the poly.
Yeah, we'll come back to your question.
Second question to my colleague Dr. Bahu. Dr. Bahu performs the calcaneal fracture. Only that you recommendation. The patient was discharged 3 or 4 days with recommendation of somehow stay early. It is not early to stay home. Anymore? We have 6. Done? Okay. 7 presenters. Number 1, Sandayo, that's good paper, fantastic. Just comment, talk to the young man, as I said previously. He has good data on post-study. Just you guys, you can work together, you can share.
Thank you for your question. So, as I'm saying, this is just a benchmark. There is no lack of studies on factors for the presentation. So, we try to identify the factors, and most of the patients who come from other facilities have a risk of delay. So, for that, we don't specifically study that part. So, it will be benchmark for to study that factor as well. So we don't really know why they delay, but we guess that they came to us because we have a medical capacity. So most of the patients come to us immediately from other centers, saying those patients probably waiting for the decision of the primary physician who are taking the paper. It makes further sense. So this is not as a benchmark to study for further.
Thank you, Dr. Amar. As you said, we told our patient as he tolerate, but we gave him very strong analgesic. Unless it is start and this time, he never go on it. And then we have seen there is no problem. After a week, even without any support, he walks. And for that's the case. Thank you very much.
All right, questions? As I was commenting, talk to yeah, no matter what. You will be asked. You both discuss. Share data out. And the question also why is interhospital care so big versus pre-hospital care? They have data. I know both sectors. You have the answer from each other. Later on, you reflect on Dr. Narendra. So, I mean, infection is primary surgery. To go with one setup, multiplying and putting another implant takes a gut and experience. Because initially, surgeons were 4 people, one stage. It was always 2 stages, but later on data showed there was not compared. My question for you is, in African sector, in developed, India now that's developed fast. But your patients still, after care will be an issue. So do you consider someone intermediate? They call it 1.5 stage. Don't go one stage, don't rush fast to one stage. Don't be all dish and stay stuck in 2 stages. Who goes twice for certain. So can compromise and come into 1.5 stage. Put spacer, wait, maybe wait.
Actually, personally, I don't believe in 1.5, and my protocol in infection is that whenever there is first presentation of infection, fever, undue pain, swelling, redness, ESOT, CRP raised, then immediately, if the patient is perioperative, say within immediate post-operative infection, diet is the procedure of choice. Debridement, antibiotics, implant treatment, and put vancomycin beads, do a complete synovectomy. You should take something like a baby toothbrush and brush the implants to remove the biofilm completely. That is the first line immediately after infection. If it is a late hematogenous infection and we aspirate the joint, and if you get the organism which is of low virulence, like say Streptococcus, MRSA is there, then 100% 2-stage division. We don't do single stage. The case which I showed was having a Streptococcus infection sensitive to drugs. So if I have that report with sensitivity proven to a particular antibiotic, and we have a low virulence organism, that is the only indication for single stage. In 1.5, I think it is not going this way or that way. So 2-stage division still remains as the main line of defense. So we take it out, then the choice of mobile or static space is there with the surgery. And then wait till the ESOT, CRP and the wound settles, and then go for the second final.
So this is just a point for
our residents, not discord anything. So the gold standard is 2-stage.
First time is 2-stage. It's a gold standard, and
2-stage.
When your OR setups are compromised, you don't have to OR switch having laminate flow or something like that. Don't go for 1 stage.
So the gold standard is when you have infected implant, 2-stage. Remove, then get up, when it is sort of sterile, put the other one. But there are also 1-stage and 1.5 stage issues to consider. As he mentioned, no viral organism, no MRSA, it's a infected patient, you go one way, like it was. In between, they come up with articulating spacer, then infected, take the debrided, open, or put articulating spacer, maybe definitely. But while you are following with articulating spacer, if infection worsens, you go again for second stage. That was the question for me. You explained that very well.
There are difficulties where, like, even after a spacer, the knee doesn't become quiet. Don't be shy of doing the second debridement. So unless it is completely get a quiet knee, don't go for the spine knee.
Sure. Thank you. Number 4 presenter was Dr. Yaya. The ethics part, be careful. This was maybe we should discuss in the ESOT. Orthopedics, when we published 125 cases, accusations, it was certain, that is done. Still, we are certain, we should improve. We should be down in the list due to prevention intervention, including saying CBD, intervention and so on. So, my point is, how do you compare these two papers? What has changed? From the previous paper that we wrote to the current paper, ongoing, what has changed? And for example, OR was in our case, the faculty, 95% of accusations emerged from OR. Now from this from here, that's one change. Such changes have been noticed. I will explain such changes. This is one question for you. For Ephraim, because I know the paper, I don't know what I will ask you. Another one. The value is good. I comment to have more expression of patients. For Saturday patients, we see more expression. Follow-up expression. The last follow-up, the longest follow-up, progressive expression. Day one, fracture, then month one, month two, month three, the last discharge. That will make it more and more residents clean. I know the method, but we need more expression. That was my comment I have for you. And actually, what we do in the cost of care is a very important. Maybe one slide. Okay, cost of care. What does it mean? If they want to copy this, we should have instructions so that they can. But the whole angle of 30 is fantastic. Quite this normal. 30 is safe 400. But we need more access plus what exactly the evidence should be when it follows decisions. Gauge the ambulance, the way he explained. I love all my students. This is not Jim fighter who operated one of the question for you is how to consider the ion, the prophylactics are considered TAD, this is considered TAD in the care. That's it. And the point you made, little courses matter. The small course I attended, muscular course, and black line will spoil you because you can put muscular stuff. But when you are alone, courses like the same is presentations. Often as you see, the last presentation from Moksha and the group, history is important. To dig until the patient bleeds. The good question, people hide, inside things. Because you all frequently asking him, he went home, he called him back, oh my God, I paid him the you got something? Patient is the last place, no. Therefore, digging history is important. They're thinking to ask from TV or so that the big person of that size is in the premise, and the patient is not easy. So digging and digging pattern is important, especially the first one. Junior social clerk ask until they are so tired and exhausted. Without serving about it, they did not. They have things in the So, dig history that is important message you should include in the information. This is what I have.
I think we have put a lot of questions already. Just additional questions from the slide. I expect patients who are bleeding to be coming in the hospital very early. Why do you think bleeding is one reason for bleeding? Like just to figure. Okay. Yes. No. There is question comes from Professor. So the change we observed from our ethical quality practice is that we can divide
in terms of knowledge, it can be the communication, it can be even the hospital setups. This all have brought some changes. For example, in nowadays, we were not considering the communication as the best remedy for our patients. After your research, after your article, and after repeated accusation of health professionals with the tool, health professional discovery that is located at Federal Ministry of Health and at Sabah, health professionals are changing in the approach, the way they communicate with their patients. The majority of the claimants, when we investigate, it is associated with communication. So that is one. The other one, when it comes to orthopedic and traumatology, there are a lot of changes now. Even for the past, I remember, for the past 6 months, there are only 2 cases came out the committee. It may have several reasons. One, health professionals may give your attention on approaching their patients. The other one, the care they give may satisfy patients, so that patients may not come for claim. That is what I've observed. The other one, with different medias, different scholars are providing different trainings or different shows regarding providing different trainings or different shows regarding makes changes among the professionals and among even the patients. These are what I observed from my experience.
Thank you. So, after we were discussing or talking some points about the referral, one thing that I forget is, if you notice, most of the patients now in this private referral system, unless there is bed, it's difficult to access those patients. So most of the patients complain that whenever they are referred to health center, there is an office here told them that there is no bed. So indirectly, what we advise them is directly go to the hospital without referral. So if somebody comes to the emergency without referral, sometimes that's better than to come with referral. So that is what there is for the review. Regarding the beginning, again, it needs further studies, but from our experience, what we saw is most of the patients come with the wound stitched. So in our process, we are strictly focusing on advising our students not to close the wounds at private hospital, because most of the fractures they need good environment before we close it. So the practice that we saw is most of the patients, the wound will be closed, and they think that is the end of the care. So that's what they are doing those setups. So whenever there is bleeding, they will directly go to the primary hospital. That is the first thing that they will do. But once they go there, usually someone will be primarily closed, and they will wait for the referral again. So that is my guess. So please try to studies.
Okay, can I add, if allow me to add on the details of continuum of care, as Professor Brook introduced me in my presentation. I have done my PhD work on trauma care system. Overall, in 9 hospitals of Sabah, I have tried to assess their continuum of trauma care. You may find one of the publications from the EMA journal already established. You can't get it from that. The majority of the reason for the delay is associated with poor pre-hospital care. That is the major finding that my research find out. When you say pre-hospital care, as you said, it may include the chain of transportation of the patients, the ambulance service, the first emergency care, the decision that the health professionals provide are major factors. The other major factor, which I found is the hospital setup with lack of infrastructure. Good example from one of the biggest hospital, which is established for trauma and emergency care. They don't have CR, so that they wait until they get paid from other hospitals, which has CR. So these are some of the major problems that I found. The other one is the referral system aid time, which takes longer to give decision. That's also my findings. Thank you very much.
Thank you, Professor, for your nice comment. So regarding including the creative practice, so we should creative practice at the time of referral, if you already took it, so we including regarding creative practice, as I present in the slide, so there is no security clearance injury, so she is young, she doesn't fulfill the criteria for creative practice, so we hope that the creative practice is also creative.
Thank you very much for the question. I think this paper was presented in SICO some 5 or 6 years back in Dubai, and in Pan-African Orthopedic Society meeting in Nairobi, and then in Kenyan Orthopedic Society meeting. This purpose I brought here, one of my students, now my colleague, from St. Paul's, he was insisting that I want to see. I can't, he's now smiling, and then I have to bring him here, not only for him, other junior representatives has to practice it. I think it is a nice way to treat this problem, and that's the case. Regarding the X-ray follow-up, what do we have? In the limited time, it is very difficult to give we cut some of our slides to consume. This limited time, that's the case. But what we see is one of, even in West Africa, they are practicing this method. They were impressed. For that, I think for our juniors, it's good practice. I think that's that. Thank you very much.
Let's thank and applaud, big round of applause. You can be seated. Thank you very much. Ulang masalah yang mana yang menangkap angkatan bertenaga. Kasar, dia ulang tahun report dulu. Masih legend itu siapa? Ulang tahun itu, kawan-kawan sini tahu sesi selalu. Executive Committee untuk kabar sejauh mana untuk amanah selalu. Hari sesuatu eksekutif kata bapak, kasar tentang komite master, komite tenaga itu apa? Jadi misalnya dulu, sampai saat karena selesai dengan soalan, anjir mana?
Zaten sınıftaydı. Bunları şahsen. Sunrise na alam nanti naman so alam na sunrise back in the country South Richmond right side of the from the part of the wall on your left would again your country the opposite on the left go down the village so since I'm managing then
Thank you. Good day.